Okay, so we're only a couple minutes over. I'm thankful. So now we're going to go through, and I have some list of questions that we've collected from all of the feeds that we have, and we'll have I'll ask the panelists. So one of the first questions, and we'll go in the order, I guess, of the talks, is for Dr. Jar Sears. So someone asked, does dormancy occur everywhere? And if it does, are all the cells the same type?
I mean, it's a wonderful question. It's really currently a very difficult one to answer because answering that question would require really a wholesale sampling of the body, and that's something that has not. You could attempt at autopsy, but we haven't taken that that extensive of a step yet. If I had to guess, based on putting together a bunch of data and integrating studies that have been done in mouse, I would guess that there are disseminated cells throughout the body, even in tissues where we never see metastasis. And I would also guess that there are differences between the states that these cells are in. I think some could be senescent, some could be quiescent, meaning that they actually could be woken up. And I think that there's a time component that the longer these cells are in this state, the harder it is for them to wake up as well.
Great, thank you. Dr. Priceman, so one of the questions that came through, I know it was two questions for you, but one of the questions that came through was, does HER2 positive CAR T cells, can it be used to prevent brain mets if a patient doesn't have it yet?
Yeah, that's such a good question. We started the trial with a thought that we would treat patients with active brain metastasis. We're now in the process, based on the safety and what we've learned in terms of the activity of the therapy, in opening a new trial for patients without brain metastasis, but with systemic metastasis, in treating them with intravenous delivered HER2 CAR T cells. And the idea would be that these might be high-risk patients for brain mets and or leptomeningeal disease, and we'll learn a lot from that. But the ultimate goal will be to start treating patients with and without brain metastasis by different routes of administration. It's a tough concept, and it's really tough to show that clinically with the number of patients that any one trial in the early phases enrolls. But what a good question. I mean, we hope that we could eventually prevent dissemination of disease.
Yeah, and the other question that came up in the chat box, is someone asked, what's the difference between intrathecal delivery and intraventricular? And I know, I'll let you go. We can, all of the panelists can chime in, but can you tell us a little bit about your experiences with your studies and the differences in those, if you've done them?
Right. So we haven't tested that specifically. Intrathecal and intraventricular enter the same fluid, but there are differences, and people have observed that in the context of other therapies. It's beautiful. Actually, Pat can probably answer that better with tracking different therapies in her studies preclinically, but we haven't tested that. It's something we thought about in treating leptomeningeal disease more effectively. Our radiation oncologist at City of Hope has suggested that on a number of occasions in treating patients with lepto or brain disease that are in particular locations. And so we are aware that there may be differences, even though they enter the same space.
Yeah, great. Dr. Stieg, the next couple questions is for you. So someone asked, does menopause do more to fight age-related metastasis than just lowering selected hormones?
Well, that's going to be particularly difficult for me to answer because mice don't undergo menopause. It's, they're a little different from us. Now, what Diana Satelli in Colorado has done is to try to artificially put these mice in menopause with a variectomy. Whether that mimics to the best degree or not, I don't know. She's been doing that and then supplementing with this hormone or this drug or that drug. And so we might get at the answer, but unfortunately I can't answer it with any data that I've generated.
Yeah, no, that's a great question. The other question that came up, which is, do younger tumor cells go more to other sites, or is it just to the brain? And I know you showed that.
So in our hands, now, I can't tell you how old these tumor cells are because they're cell lines that have been in culture. So it's a younger host or an older host. We did liver, lung, and brain. And of those three, it was only brain. I can't tell you that it won't be other organs as well.
Got it. Okay, great. Dr. Anders, so we have a couple of questions for you. So one of the questions in the chat box is, lobular cancers can go to the leptomeninges. Can you talk about treatments for this, and should metastatic lobular patients get routine MRIs?
That's a great question. So about 30% of breast cancers are lobular. About 60% are ductal and arise from the ducts of the breast. And there's about 10% of other, which are more rare types of breast cancer. One of the hallmarks of lobular breast cancer is there's a lack of an adhesion molecule between the cells called E-cadherin. And in fact, that's what our pathologists look at to determine if a tumor is lobular or ductal. So by nature, instead of grouping together in more of a spherical metastasis, lobular breast cancer tends to line organs such as the pleura, the coating around the lung, the peritoneum, the coating around the GI tract, and then the leptomeninges that protects our brain. So I think we certainly see this in the clinic, and I think another thing that we really need to understand is how should we be treating lobular breast cancers differently than ductal? And I will say right now in the clinic, they're treated relatively similarly, but based on their biology, they probably, I think over time we need to develop better strategies. In terms of treatment of leptomeningeal disease more globally, I think essentially there can be kind of two types of leptomeningeal disease. There can be diffuse carcinomatosis, where we see this sort of, we call it a sugar coating of the leptomeninges, which is just a fine film of tumor cells lining the leptomeninges around the brain, and that can also go down the spinal cord. We're also seeing nodular leptomeningeal disease, which has a different behavior. So more discrete areas along the dura. So I think the first thing there is diagnosis. We use MRI, brain MRI, and then we also use sampling of the cerebrospinal fluid. And if patients are symptomatic, with either headaches or nausea, dizziness, we give steroids. And our first line of defense is usually whole brain radiation therapy, really just to halt the symptoms, really treating the symptoms. And then moving into the systemic therapy space, there are several different options. You can use systemic therapies that have a better chance of crossing the blood-brain barrier. I saw one of the questions in the chat box was around abemaciclib. In fact, we do have some data for abemaciclib with leptomeningeal disease. We also have, and it's been really interesting to hear the conversation around intrathecal versus intraventricular therapy. Typically if we're going to do what I guess I've previously called intrathecal therapy, we do it through an omaya, which is a port placed on top of the skull, but actually burrows down into the ventricle so that we can give repeated administrations of chemotherapy, sometimes twice a week, as opposed to having to do repeated lumbar punctures, which can cause a lot of challenge. So in essence, we're probably actually giving intraventricular therapy when we give intrathecal therapy. So it's just something that's been interesting to hear today. And I think, I think right now we typically give chemotherapy, methotrexate. We've also seen data for trastuzumab into the CSF, and I'm very fascinated by the CAR T cell delivery into the CSF. So I think there's a lot of development here yet to see, but those are kind of our initial decision trees in the clinic.
Yeah, that's great, because I mean, what you described of even within, the locations of the brain mets, whether it's, in the front or the back, that actually really, addresses that concept of the tumor heterogeneity, right? These tumor cells have now changed, and it gives some tumor cells proclivity to grow here versus back here. And we've had studies underway looking at patients as well, looking at what we call topography of brain mets. And so, yeah, the map of the brain, which is very, very important. And as far as, yeah, I mean, intrathecal versus intraventricular, I mean, it's just different it's just different rooms, but they're all connected by the same hallway. So, but it's also, yeah, like what you described, is trying to give patients the best route so that they don't get infected while getting therapy and the pain. Can I ask you, and you addressed a couple of other questions within yours, but one overall topic, there's a long question that came up, but and this by far is, of course, is not medical advice at all, but could you give, as a medical oncologist, if a patient was diagnosed, and this was, I'm abbreviating this question, if a patient comes in, and they find out they have metastasis, could you give 1 or 2 pointers of what should they be asking their doctor next? Of course, it's not medical advice, and every patient, needs to consult, but just if you can give 1 or 2 simple questions they could ask.
Sure. So I think one, understanding the subtype, right? Because so many of our decision trees involve subtype, just the way that I organize my presentation. We think about, breast cancer is not just breast cancer anymore. It's multiple different types of breast cancer under one umbrella. So really understanding the type of breast cancer that an individual has is very empowering and really helps understand the treatment algorithms and the rationale. I think the other thing that has really been a paradigm shift in how I trained in oncology and how I practice now is going one step beyond subtype to next generation sequencing. And when I see my patients in clinic, I always offer them next generation sequencing on preferably a metastatic tumor biopsy. And what that means is essentially getting gene alterations, whether or not it's mutations, deletions, amplifications across hundreds of genes. And that really helps guide our therapies now. We have FDA approvals for therapies that target estrogen receptor positive, HER2 negative, PI3 kinase mutant breast cancer now. We're picking up alterations in the BRCA genes that the patient didn't inherit, but actually happened in the tumor itself. And that has shown some activity. The PARP inhibitors have shown activity there. So I think, really number one, understanding subtype, but then also going the next step to understand the molecular changes in the tumor. And that's something I would just, if the physicians haven't offered in the metastatic setting, would be something that I would certainly ask about, because many of these tests are FDA approved and covered and have been, they've really changed the way I practice medicine.
Great, thank you. And last question is, Kathleen, you brought up this idea of, this whole, cognitive, decline. If a patient wants to come in, or if a patient wants to, act as a healthcare worker, or if a doctor like yourself, how, would they be talking to, their oncologist, or how would a patient, if they're not at UCLA, for example, that was one of the questions that came up, ask?
Yeah, so it's a really good question, and there certainly aren't as many providers as I wish there were who are assessing and addressing these issues. So I think, seeking out help from rehabilitation specialists like occupational therapy, speech language, if those issues come up, and neuropsychology. So asking if those resources are available wherever they are. And for an assessment. I think it's important to keep in mind, though, that what we find in the literature is the types of problems that people have often don't meet any criteria for a neurocognitive disorder diagnosis. Doesn't mean that they don't exist and that they're not problematic and need to be treated. It's just a bit of a fine line when, you see someone and their cognitive performance looks okay. It might be that they've had a decline. It's just not so severe as someone who has dementia or something like that. And so I think it's important for patients to keep that in mind, that their concerns are valid, no matter what the actual objective testing says. Right. And that, I wish all all providers had training in cancer, but if they don't, your concerns are valid. And, you know, and just continue to find someone who you can work with, like someone in the rehabilitation community.
Okay, great. Thank you. Okay, with that, I know we're, you know, about 10, 15 minutes over, but I really want to thank all of you, you know, all, you know, Pat, Carrie, Kathleen, you know, Cyrus, I see Alana there, Saul, who had to go to another meeting. Really want to thank you all for, you know, your wisdom and your pearls and updating, you know, all of those participants that were on. I hope that, you know, like, you know, making lemonade out of lemons. I hope that, you know, even, you know, we'll be back to see each other at conferences in the future, but I hope that we could still do this like Zoom has, you know, this one positive aspect of COVID is now we've all become virtual folks, right? And we can, you know, continue these conversations with patients all around, I'd say the world, because, you know, that's where this is reaching, and patients could benefit, you know, from these kinds of conversations. So I want to thank you all again, and to all the folks that are out there. And I hope you guys all got a very useful day out of this. And hopefully we'll see you soon. And I hope everyone stays healthy. Thanks, everyone.
Thank you, Josh. Thank you all.
Thanks, Josh.
Okay.
Take
Bye,
care,
guys.
everyone.
Bye.
Bye. Bye.
Bye-bye.